Let's call the meeting of the Medical Advisory Ad Hoc Committee together. I appreciate everyone being here. It's always fun. We have a couple people who are on virtually. And just going to bring up the, so you got the video up?
Ryan, are we good?
Yeah, it says reconnect. Okay.
Okay, so we'll call the meeting to order. You should have your packet of information was in the agenda and on board book. And I'm trying to bring up the agenda now. Can't even get on the agenda here. Thanks. So roll call. We do have one board member absent, Brian Hafer. But Jack is here. I'm here. We can go around quick. Is there anyone we're missing or waiting on?
I see everyone, if you just want to skip through that. We're
Okay.
waiting for Sarah. She's just running
Sarah's
a
going
little
to
bit
run a
late.
little bit late. But I see Potoff, Anderson, Seidow, Aaron made it on, and Valerie. So I think those are the ones you were expecting virtually? Okay, then we just need a motion to approve the minutes of last meeting, which were attached to the board book. And
So moved.
Second.
all those in favor say aye.
Aye.
All those opposed or have a comment? Next is approval of the agenda for tonight. Is there a motion to approve the agenda as written?
Motion to approve is written.
Is there a second?
Second.
And a second. All those in favor say aye.
Aye.
Any opposed? And then the first thing is to review progress on our current dashboard data.
Right, so to start off with, I just want to say, first of all, thank you to this committee. This committee has been vital as we've gone forward with planning all of our protocols and procedures and bringing students back to school. So this past week, we were able to welcome back, after a surprise snow day, bring back our 5th through 12th grade students. Having been in the buildings and being able to kind of watch how that progression has gone, compliment all of our staff and everybody else who's been part of just making all of those logistics and pieces come to life. I feel like the feedback that's come from this committee have allowed us to put things in place in all of our buildings now that I feel are truly able to mitigate the risk to the greatest degree that we're able to. So I appreciate all the work that's gone on there. I'm going to ask Kurt to walk through some of our data because we're certainly seeing some trends that are developing here with regards to in a positive direction. So I'll let Kurt walk through the data that we have in front of us. And Kurt, we can also bring those things up and share the screen so that everybody can see. Want me to do that?
Yeah.
All right. Which one do you want to go through? This one?
Whatever you want, your pleasure.
All right.
All right. So this is just an indication of staff and students who have been tested positive or close contact. Our numbers, they do increase each week as we would expect. I wouldn't say any particular building is having more cases than another. I think our numbers are relatively stable in this area, and we've got a lot of people who've been cleared from close contacts or positive tests. Just as a reminder, we did adopt the CDC, Department of Health Services and Public Health, Madison-Dane County options to have a 7 or 10 day quarantine in substitution for the 14. And we've had a number of families take advantage of the 7-day option where they've gone out on day number 7, got tested, and have had a negative test, which allows them to come back a little bit sooner, a couple of days sooner in most cases. So families are doing that. And that's at all grade levels. It's not limited to one building. It's at all grade levels that families are doing that. The next series of tables will jump to table number 7, which is the current information. What we have what we have at our table doesn't show 2.1, but 2.1 is out there. So it's up on the screen, 417, 19.05, 3.14, 4.07, and 20.24 for a burden rate. Again, as you can see over the course of the last week, and you can go back through the other 6 tables if you would like, our burden rate is at a pretty low mark compared to where we were. When they first put the school district data together, the very first 14-day burden rate per 100,000 that we could calculate was 55.74. And now we're sitting, and that was on October 24th. And now today we're at 20.24. So pretty nice improvement there with that. And then the county data, which is the very last chart that we have available for you. Again, they post their information on Thursdays. We post our information on, we prepare it Monday for a Tuesday posting. As you can see, the trend there is the percent positives are going down. The burden rates are going down across the county as well. So, it's good. The data is good. We'll see if it continues as we move forward with that. And then the other chart, if you want to look at just our school data for a moment. Hold on. A little hard to see, but go to the tables. I'm just going to highlight, as you look at each of these tables, the trend is that we're coming down. It's a downward trend. So that's positive news as we continue to track this on a daily basis. And again, this is all school district data. It is not the census tract data. So this is the makeup of the school district community. I don't know if anybody has any questions or thoughts.
I do have a question on the first table. I thought, maybe my misunderstanding, that when you had the staff positive cases and close contact cases, you add that together, you then take the staff cleared from positive or close contact, and that difference was how many were currently in those categories, right?
Correct.
But then if you look over at the student, you take the student positive close contact, it comes out to about 570, but supposedly we've cleared 600.
Correct. We have a lot of students who are in a quarantine or an isolated place right now.
Well, then shouldn't the close contact and positive numbers be higher than the 609?
No. If you add the positive cases and the close contacts, the best they're ever going to be is equal to the students cleared. Because the students cleared column reflects that a student who tested positive has met their 10-day isolation, and that a student who's a close contact has met their quarantine. Then they're cleared. Then they moved into the cleared category.
And you take them off the positive and you take them off close contact?
No, it's a running total of everything. So
That's why I'm not understanding, because if the positive case and close contact are a running total and they're at 570, how could you have ever cleared more people than you've ever had it?
Oh, that's a good question, Dave. Sorry.
I need a math teacher.
I'm sorry, Dave. I must have hit a wrong button on my calculator.
Oh, okay.
That's a good point. That's a good point. I bet that's 509.
Probably.
Can anybody do math quickly? 8, 7. Well, I will get this corrected.
Okay, so that, I wasn't misreading.
No, you're right, Dave.
Can you send that to my wife?
I will do a quick calculation and let you know if I have an answer for you.
Does anyone on the Zoom have any questions about the data at this point? Comments? Nope.
I think I'm just going to ask the same question I asked the last meeting. Is this similar to the trends that you're seeing in the clinical settings?
It is. We're definitely seeing ongoing declines in case count rates and test positivity rates, so very similar.
If you had that student, you're wondering about the student cleared from positive test or
Yeah.
close contacts at 6 to 9, that's what it is if you add those numbers up.
Yeah, that makes sense.
It's probably a 582 curve in the other one.
Yeah,
That might be where it is.
no, I don't think so.
So,
I'll get it figured out. We can move forward and I'll get you the right answer.
It's fine.
yeah.
Um,
So overall, I think, just as a kind of a summary of this part, our numbers are obviously trending in the right direction, which is positive. Our contact tracers and checking in with them have definitely not been as busy as a result of the numbers coming down. And again, as we kind of are bringing more students back to school the last few days, we haven't seen any sort of an uptick in our numbers. Brian's been working with our substitute teachers, and we've been able to manage at that level as well. So I think overall, we're sitting in a good place, given where we're at with bringing students back and the activities that they're involved with. Brian, anything to add just from a staffing standpoint? Because that was kind of one of our main pieces as we started off this journey to bring our students back.
No, at this time, our staff we've not put ourselves in or not been in a situation yet where we've not been able to cover for a sizable number of staff that have affected our ability to keep buildings or classrooms operational. There certainly have been a few cases of where we've been short a substitute or two for a position, but nothing on a large scale that's caused any need for closure or change in delivery model.
Okay, great. Anybody have any questions or comments on either the transitions to bring in more students back or any of our data pieces? All right. Now, we just keep moving, Dave?
And there, yeah,
What we're looking for tonight is we have a number of things that we either have some updates on, but that we would also like feedback from the committee. Many of us joined the Public Health Medicine Dane County for their weekly call, where they have their liaison to the school sector working with us and sharing with us what's happening within the management of this from a county perspective. The one piece that has come up recently is that the UW has antigen testing available that can be supplied to school districts. Their purpose is to be able to have an antigen test available at schools for symptomatic individuals. So it's not a screener. It would only be for those who are exhibiting symptoms and then having an antigen test available. The question that we have for the committee tonight is this something that we should be pursuing? And if so, do you have any recommendations on how we would use these? And are there any things that would bring you concern? And we bring up the last part because I think when we talked about this, probably late summer, early fall, this was a piece we kind of steered away from. But certainly right now there is an availability to be able to participate in an antigen testing program, and we'd like feedback from the committee on what your thoughts were.
I think one of the key things to think about, know and remember with antigen testing is in a symptomatic individual, if the test is positive, it's helpful and you don't need to repeat the test. But if the test is negative, you do need to follow it up with a PCR. And so if the intention or the thought was that students who test negative will be able to come to school, I would say that would not be the case. So you would really need to still have that person go to a health system and or the Alliant Energy Center to get their follow-up PCR testing. So it's a little bit hard for me to see, exactly how beneficial it is, other than the fact that, somebody could be diagnosed as a positive earlier, and it might give you a little bit of a heads up on that. But that person still would have to be going home, and I think just from a standpoint of labor and knowing that you guys are stretched, I think would be a question about is the benefit worth the cost that you would have to do to stand it up from a labor standpoint, and still knowing the kids have to go and still be tested elsewhere if they're negative.
Okay.
Yeah, I think the benefit would be particularly as a convenience to those families that maybe don't have readable access to healthcare services, i.e. they don't know where they would go get their test if their kid had symptoms. So there you might offer some benefit in that if you do the test and the test is positive, it's probably a legit positive, you can take action on that. Like Matt says though, if the test is negative, the sensitivity and specificity of those antigen tests isn't so good that you could rely on that negative antigen test to rule out a symptomatic person who tests negative. They would need a PCR confirmatory test. So you'd want to figure out where does that happen, or what's your process for a symptomatic kid, antigen is negative, you're not done there. And then at that point, is it easier just to develop that process for any positive kid where you outsource that testing? But I think in my mind, the benefit would be for those families who don't have easy access to healthcare, you'd be providing that test.
Okay.
Would it be helpful in the sense that if someone tests positive, then they wouldn't then have to go get the full test? I mean, it would help them quicker to know where they need to go.
Yeah, if they're symptomatic and they have a positive antigen test, they're done. They're positive, and then they follow the isolation workflow that a positive person would have.
But wouldn't it be better just
The thing that would
to,
need to be really important if you were doing it, I think, to Jeff's point, I think there could be some access benefits with it, is if that person who didn't have access to healthcare was negative, to make sure that the family knew, and there's always some concern that somebody could feel a false sense of security. I tested negative, so now I don't have to take the precautions. So the messaging is really important. The other thing to know with the antigen test is that it is time sensitive, so that has to be run within a certain period of time. And so you'd have to identify, where are you going to test those individuals? You don't want to bring them into the school while symptomatic necessarily. So, where would be the site that you would do it? How would you do it? And you have to have somebody to complete it. I forget the exact timer. I think it's within like 90 minutes. Or Jeff, do you remember? Yeah. So
It's 90 or 120, yeah.
Yeah, you can't package it and then wait until, somebody comes on site later. You have to batch them together and do them in a coordinated fashion.
wouldn't it be better just to set up some transportation to the county site? If there was
And
somebody.
I think that's what we're trying to determine is one, because it's specific to symptomatic individuals. The piece I didn't understand is what Jeff, you and Matt explained with regards to if somebody's negative, that still prompts them to have to go get a PCR test. All it really does is it gives us a quicker answer to the positives, of which then we can address that.
How many students would fall within this in a daily period?
Jenny, do you have an idea of how many students would be symptomatic on any given day while they're here at school?
Trying to think of today, I think there were maybe 2 that I know of. Oh, hang on. No, I take that back. They were not at school. They were called in sick. I don't think today we had any.
But
Yeah.
within the district, if we started doing something like this and the kid was going to call in sick, we'd almost in a way want them to come in and take it. So how many would fall within that type of a category? Are we talking 4 to 5 a day, roughly?
Yeah, I think it's hard for us to know exactly how many symptomatic students we have, because one of the things that we put an emphasis on is if your child is symptomatic, don't come to school. So I don't know that we necessarily have accurate data. We certainly know students, and I think this is also relatively small, Jenny, you can add to it, but I don't think we have many students that when they enter school and they're not symptomatic, that they become symptomatic. I think that's very small. Is that right, Jenny?
Yes. I mean,
So,
a week or two can go by before we send a kid home who's actually in the building that develops symptoms once they get there. It's very minimal.
so if you wanted to do this, would you do it at the wellness clinic? You know, because you don't want to bring those kids to the building.
And I think that's part of why we wanted to have a conversation here, is we've been trying to figure out what benefit does this give us? I mean, just given a better understanding of what the results mean, it doesn't necessarily clear a kid to just say, well, you don't have COVID just because your test came back negative, you're gonna have to still have other testing. Doesn't prevent that, which is, I think, something that would have helped, is if you had some sort of an answer like that. But it's also the piece of, do you want to bring kids into school who are symptomatic? Is that something we want to be practicing? I would say that gives me a little bit of concern. And I think that's, Kurt, what you and I talked about, was we don't want to have students coming to school who are symptomatic, knowing that then there could just be a preemptive test taken, and then you kind of have an answer. So does anybody on the committee see a huge, other than what I think, Jeff, what you talked about, which is some of the access pieces to testing, is there anything that this gives a huge benefit to us or helps us manage our students better by having the antigen test? I'm just trying to figure, given the kind of how those results are impacted and how it could still prompt them to have to go somewhere else to get a more accurate test, I'm just questioning if this is an avenue we should go down at this point.
Yeah, I think the only way that you add benefit to it is if you have a negative test, you already collected the swab needed for the PCR, and you've established a connection with someone locally who runs the PCR. So the kid goes home, but you've taken care of the confirmatory testing. Now the family hears in a day whether that kid is truly positive or negative, and they don't have to seek out that confirmatory test on their own. But I think just to offer the antigen test and then not have that follow-up kind of automated,
Right.
I'm not sure it adds you a lot, because if you're positive, you're positive. If you're negative, you just don't know if you're positive or negative.
Yeah.
So are you suggesting that if we had the antigen test, let's say we sent them to the wellness clinic, they take the test, you can then use that same swab to send it in for the PCR test?
Depending on how you do the swab, if it's a nasal swab, maybe, depending on who's doing your PCR, you'd have to figure out based on your PCR. I think, Matt, correct me if I'm wrong, but I think at UW Health we do spit, we do nasopharyngeal, so like our PCR test wouldn't be a good candidate for follow-up on the antigen unless it's collected a little bit differently.
Okay.
Yeah, I think, I wouldn't swear to this, but I'm pretty confident. So I know that in our antigen pilots where we've tried to use it and we've actually backed away from it at this point, we have used 2 swabs, and there are some lab limitations around that. So I think getting it with 1 swab is fairly difficult or not feasible.
All right. Brian, you have something to add?
Something that I think we need to, before we get too far down the road, I'm not sure that taking these tests at our clinic would be an option, because right now our clinic steers all symptomatic individuals to the specific SSM sites that manage that care, and our clinic is not one. And so we would have to obviously work through that with them to establish whether they would allow that. And whether, or would they still push avenues to, Dean West being the closest location for urgent care where that testing does occur.
Do they do that testing in Waunakee?
No, I mean, you have to take a screener to be able to have an appointment at the clinic, and if you're exhibiting symptoms, you're actually pushed to go to a different site within the SSM system for care.
I seem to remember the discussion with that was that going to the Alliance Center gives you a faster answer. Going through SSM can take days, unfortunately, because of the limitation of where you have to go.
So given kind of that feedback, I think maybe right now we just hold on this. You know, there's a couple other districts that are doing some experimentation with it, and we can see kind of how they're utilizing it, what they learned from that process. We could bring it back here if we find some value that they're bringing to it. But I guess given the feedback that's been offered, I think I would probably want to hold right now until we had some better idea of how that could benefit us.
I agree.
Anybody agree or disagree with that? Makes sense?
Makes sense.
All right, great. Thanks for the feedback on that. That was one we really value the input. The next item, we just want to provide the committee an update with regards to where we're at with the vaccine. And Brian Grabarski's been working diligently to help identify that for our staff. So Brian, if I could just have you kind of give a high-level overview of where we're at right now, what that process might look like for us. And then we do have some questions with regards to the vaccine that we would value your input on. So Brian, do you want to give a little update of where we're at?
We've been in communication with SSM. They've indicated to us that they'll be our assigned vaccinator for our 1B employees when they become eligible to receive the vaccine. What they have seen is they have seen the supply for vaccines slow slightly. So they are continuing with the premise that the March 1st date is the earliest possible date, but they also have communicated that despite what we've seen in other health systems, surrounding counties, they are very closely going to follow what DHS lays out for a rollout of eligible individuals. We do have and continue to have ongoing meetings with them about how this might roll out to our staff, and are very hopeful that we've come to or are coming to a delivery mechanism that will be both convenient to our staff, provide us the highest degree of access that we can have, but it certainly remains to be seen how that and when that will begin.
So we've got 117 vaccinated now. When we go through 1B, how is that 50% of our staff? Is it?
So 1A is the only folks that we've had vaccinated at this point. 1B is defined as all personnel within your district. So that extends beyond just classroom teachers. It extends to all district employees. We're looking somewhere north of 600, approximately total 600 and change employees, and so we're a little bit over 1/6 vaccinated at this point. Without knowing of those others that have could or will become eligible, will they choose to take the vaccine or not? That's not a question we've asked at this time. But we will obviously, when scheduling comes to be available, employees will be given that option of do they pursue it or do they not.
So I think some of the pieces that we've looked at, and obviously that's been really positive to kind of have a plan moving forward. We also realize that the supply chain issue with vaccines is probably the biggest limiting factor for us. But process-wise, it looks like we're at least starting to define that for our employees, which is absolutely a positive and a thing that we'll continue to be very proactive with. A few questions we have for the committee is really just some definition of what the vaccine is and what it provides and what it does not provide, which to me seems like a question that doesn't seem like an intuitive question, but as I think about the vaccine just as I think a lot of our parents, our staff, and community does, is that once you're vaccinated, it means I can't get COVID. And I think that's kind of what the general population believes. What we've been seeing and reading is that's not necessarily the case. So what we wanted to do was kind of pose that whole question here is, when we have staff and we have community members who are being vaccinated, obviously a really positive step in the pandemic. But what does that vaccine provide, and what are the things that we also have to be aware that it's not providing, if that question makes sense?
Yeah, I can take a crack at that, and Jeff or anybody else can fill in. So as far as what the protection the vaccine provides, there certainly are people who have had positive tests after an infection with COVID after being vaccinated. So I think key points, after that first dose, you're getting, a week or so later, you're getting about 50% protection, and then a week or more after your second dose, you're getting up more than that 95% when you're talking about Pfizer and Moderna. It's going to get a little bit more complicated when the Johnson & Johnson vaccine comes up. There's been some publicity and data around that, so that may be coming up here in the near future as well. That's a little bit less efficacious, but did a good job at preventing serious illness. So that 95% number means that people are protected better from acquiring a COVID infection, but does not mean that they can't get it, to your point. What it also does is it prevents, lowers the risk of severe illness from COVID. So even those people who get infected tend to have less severe consequences from it. That's similar to flu and what we see with that vaccine. So those are, real positives. So what it doesn't do, like I said, it doesn't mean you can't get COVID. What it also doesn't do, and we're really trying to stress very clearly, is it doesn't mean that you don't have to wear a mask. It doesn't mean that you should go out and do all the things that you want to do, meeting and gathering with other people, going out and eating out at restaurants and doing all of these things that we've been recommending against for some time. The other thing that is clear that it does not, that we don't know at this point, is we don't know if you're vaccinated, that means that you can't transmit COVID to somebody else. So meaning that you could be protected, but if you're carrying the virus, there was some publicity recently about a congressperson who tested positive after having had both doses, but was asymptomatic. We don't know if that individual could pass it on to an unvaccinated person, for example, even though they didn't have symptoms and had already been vaccinated. So that's something that we'll learn more about in the future. So, one, protects you against severe illness, protects you against getting the infection, but doesn't mean you can't get it, and doesn't mean you can't transmit fully. So the key things are to watch the community spread rate. We think that those will go down, and as we get the community spread rate down, we get more people vaccinated, there'll be more protection, and we'll be able to go back to a more normal pre-COVID state, but that's a number of months out because of the supply issues and otherwise, as you mentioned. So I think those are the key points there. There are obviously a lot of nuances within that, but that's the sort of overarching view, and Jeff and others can, chime in where I left something out.
No, I think Matt got it. I think I look at three things. So, people, they wonder if they can get it or not. I think we have to break that down. So, can you actually carry the virus after you've been vaccinated? We think the answer to that might be yes. And therefore, if you can carry it, you might be able to infect other people. And that's where the masking guideline comes from. If you're vaccinated, the likelihood of you getting sick, and for sure the likelihood of you having severe illness is really low. But that doesn't mean that me, vaccinated as a healthcare provider, couldn't take it home and now infect my wife and kids because they're not vaccinated. And that's why you continue to see the masking and distancing guidelines. Now, once we're all vaccinated, it doesn't quite matter whether we're passing it around. None of us are getting sick anyways. So that's why once you have that, herd immunity number, 80%, maybe a little bit less immunized, you really don't have to worry about it because everyone is protected. And then there's the efficacy numbers you hear. So Moderna, Pfizer, 94, 95, Johnson & Johnson, 60 to 70%. That's for, do I feel sick when I get the virus? Do I have symptoms? If you have the Moderna or Pfizer vaccine, 95% of people aren't going to have symptoms, even if they're carrying the virus. With the Johnson & Johnson, it's a little bit less, 60, 70%. But then probably the most meaningful data point you want to look at is, if I get vaccinated, do I get so sick that I need to go to the hospital, or do I get so sick that I die? And all three of those vaccines right now prevent that severe disease, that death from COVID. And that's probably the thing that matters the most. I think most of us, if we were able to get the Johnson & Johnson vaccine right now and knew that we might have some mild symptoms for a few days, but we weren't going to get really sick and we weren't going to die, would sign up for that instead of waiting a few more months for a Pfizer or Moderna vaccine. And I think that's kind of the takeaway. I think Matt hit the rest of it. I mean, if there's more questions, we can answer questions about vaccine. We get a lot of these, so if there's something on your mind, just shoot it out here and we'll let you know what we know.
Could you take both vaccines? Yeah, like if you get the 60% early, but then in summer you get the 90, or do they affect each other?
You probably could. I think the other thing that you're going to see is as these variants are better understood and we understand different variants and their ability to defeat current vaccinations, especially with the messenger RNA vaccines, it's very easy to tweak them to be effective, like really effective against variants. You might have boosters of these mRNA vaccines that are, even more effective than the current one, and that might be something that someone who maybe initially got a Johnson & Johnson vaccine gets at a later date, which offers, everyone to be getting those boosters if these variants keep changing.
I think the biggest limitation with that in the near term is going to be just the supply. To get a second one before somebody else has had the opportunity to get a first one is going to be pretty challenging. So we also don't know the duration of immunity, so whether we're going to have to tweak for the variants and do this, over again, but we'll be better protected at that point. It'll be more tweaking to kind of improve from a pretty good foundation and baseline. So anything with that is probably a ways out until we get the majority population vaccinated.
Right.
So I've got a question. We are following the public health recommendation that if somebody actually tests positive, they have like this 90-day grace period where if they are exposed to somebody else, they don't have to quarantine. That is not true, at least that's what we're following. That is not true if you've had the vaccine. If you've had the vaccine and you're exposed to somebody who tests positive, we are quarantining them. Is that correct?
I haven't heard that distinction specifically. I mean, we could look into it. But, to be quite honest, I'm not sure why one would be different than the other, because in many cases the vaccine is more protective than natural immunity. So I'm not sure why that would be, but I'm not going to say that it isn't because I just don't know.
Right, yeah, I agree with Matt. It looks like artificial immunity, i.e. vaccine immunity, is probably a little bit stronger than natural immunity, so we'd have to look into that statement a little bit. It just, on its face value, doesn't quite make sense to me, but that doesn't mean there's something I don't know.
And was that from public health?
Yeah, that's from public health. Yeah, that is from Public Health Madison-Dane County.
So that's something we can follow up with. Are there any other questions with regards to just what the vaccine does or does not provide before we move on from that question? I think that was helpful. The next part with the vaccines is really just if you have any insight or update on what this might mean for individuals who are under the age of 16.
I think the key thing there is that those trials are ongoing. They're enrolling children across the country, in other places in those trials to identify safety and efficacy, the same things that you saw with the original trials that were done in older populations. So that's all a little bit of TBD at this point until we have that data back from those organizations. And I have not heard anything specific about timing. I don't think that's coming anytime real soon. You think about the enrollment periods and then having to follow those individuals over time. And so I think more to come, but I don't think it's anytime real soon.
I think the thing you might see happen, though, is if the rollout is slowed and if we start running out of vaccine and we start delaying our 1B and, further distributions, it could be that information starts to come back when those people are actually starting to become eligible for vaccine. So it might dovetail nicely, even though it's not ready to go right now.
Great, thank you. Any questions about vaccines or anything related to vaccines or as a follow-up to what we just talked about? All right, excellent, thank you. That's again helpful. The next item we have is just wanting to share with you a few things that we are finding with student privacy and COVID-19 notices. Something that, Kurt, you work through on a daily basis, and Jenny, you're often involved in a lot of the contact tracing in those conversations. Kurt, can I just have you kind of walk through what we were doing and kind of some of the things that we're transitioning to? Because this was a piece we brought early on in our medical advisory committee with regards to how we are trying to be as transparent as possible without giving out too much information that kids can be identified or adults can be identified.
So internally, when we have an individual who tests positive for COVID, we have been, up until last week, we had been copying the building administration, attendance secretaries, the teachers that the student had, and the counselor at the upper levels who the student had. Some parents raised some concerns about the sharing of that medical information. They were thinking it was a HIPAA violation. So we made a modification where we're only copying on the message that the building administration, the attendance secretaries, and the health office staff. We're not copying the teachers anymore. And of course now the teachers are concerned that they're not getting the information about students. And it isn't what a few teachers who've reached out to me have shared with me is it's not the concern of not getting the information about the positive test. It's they want to know how they can reach, because now they're not getting the information. They're not able to reach out to the student now and the family to provide support as they're moving from a hybrid model to a virtual model. So we're trying to balance the communications so that staff can know but preserve the privacy that everybody is entitled to have in our system. So I guess thoughts on that, because we understand what the parents were sharing with us, so we made a modification, and now the teachers are feeling that without that information, they're less able to provide some individual supports to some of the students that are no longer coming into their classroom right now. So we don't know where to go.
What are we doing with current students? Like, if they don't have COVID in the past, I was sick.
That was a great question, Jack. And so I asked that. I emailed our attendance administrative assistants and I said, let's go back to pre-COVID days, which everybody loved doing, by the way. Everybody loved going pre-COVID. And I asked them, when a parent would call in and say, my child is ill, they're not coming into school, what did you do? And they did not, for the most part, they did not send an email to the teacher. They would enter it into Infinite Campus as an illness, and then when the teachers would go into Infinite Campus, they would see the student was marked absent, but there's a slight delay for that. It's not an automatic thing because the attendance calls come in throughout the morning, so some teachers would go in there and see nothing, so they didn't really know what was going on. Like at the high school, for example, it may not have been recorded until midday, so those first block teachers wouldn't have any idea what was going on. They just knew the kid wasn't in their class.
What do we do with students now as far as you don't send an email to the teacher, but are you still putting it in Infinite Campus?
We are, yes. We are doing
It's
that.
coded in there.
So it just says illness, it doesn't say what the illness is or anything like that. But they know that the student's going to be gone, so they could reach out to the student, just like they did before.
We actually created a series of COVID codes for illness because COVID can impact you in a number of ways. COVID can be such that you can't participate in school, so we need to track that as an absence. For kids who are hybrid, if you're no longer in school but you're switching to virtual, you can participate, so we don't want to count that as an absence, but we have to mark it that it's different than what they were doing. So it's COVID VP, I believe, is that one, when you move from hybrid to virtual programming. So we have this series of codes, so teachers would see these COVID codes, more or less, which kind of tells them it's related to COVID in some way, shape, or form. But we needed to set it up that way because some of those absences get reported as true absences, and some of those absences don't get marked, at least when we do the math at the end of the year for some of the reports that Tim Shell has to submit. it's not a real absence, because they did engage in the instruction. So we had to set up that system of COVID codes to accommodate for various combinations that has resulted in COVID and students' ability or non-ability to participate in some kind of education.
So if you went back pre-COVID, you were absent or you're not.
It was excused absence or unexcused absence.
Unexcused, and the teacher saw that and could react
Correct.
accordingly. So now what you're doing is you're putting either excused or unexcused or COVID BP or COVID absent. So that teacher still has that same information, right?
They would.
So
Yes.
if it's COVID VP, then the assumption is that this kid's going to be out for 7 days.
Or 10, depending.
7 or 10
Yeah.
days.
Yeah.
So, the teacher should be able to go into the system and say, hey, what's going on here? So that instead of getting the email, they're still getting
Right.
the information.
Yeah. So let me bring Aaron into the conversation. Aaron, as a classroom teacher, does that make sense what Kurt was explaining as far as kind of entering those and the coding that happens within Infinite Campus when you're doing attendance? And that gives you.
Infinite Campus already has built-in purpose stuff, so I can dig it, yeah.
Okay. Yeah, I guess that's kind of what we were looking for, just some feedback, but if that makes sense from it, as it's getting entered in at the attendance desk, you can see it as a teacher without getting the blasted out email, but you'd see it in your individual attendance list that's coming through IC.
Yeah, as long as we know what's going on. More and more classroom teachers are taking on the responsibility of mental health, and we can't do that without information.
Yeah.
So weirdly enough, this really isn't a student privacy issue because they're getting the same information no matter which way you do it. It's just how they get it.
Correct.
So as far as HIPAA, I don't see a difference between the two methods. Unless
Well,
I'm
with an
missing
email,
something.
you can send that, blast that all over. With the Infinite Campus, you gotta,
Infinite Campus, it's only in Infinite Campus.
yeah, you gotta log in
Yeah.
and, and you're probably seeing your block of students.
Correct.
You're not seeing the
You
entire
don't see the whole
population.
school.
Right.
And there's also teachers already sort of predisposed toward not sharing anything in Infinite Campus with other people.
Does that help, Kurt?
Yes, I
All right,
think so.
thank you, Aaron, that helps us, and beautiful. Kind of moving on, and Aaron, it just kind of builds off of what you just talked about. And one of the things we had a few meetings ago is we had some of our staff and folks here, we were talking about mental health. That's obviously been in addition to getting school started, it's been probably the parallel conversation we've all had with is how do we address and work with kids with some of the mental health challenges that exist today. We're going to be talking about some things that are short-term and longer-term at the board meeting coming up next week. But what I wanted to do is bring this piece back. We've been asked quite a few questions from parents just as far as how we're meeting some of the needs of our students. We've tried to add things into the schedule that allow for greater connectivity to kids. So one of the questions we wanted to pose here was, when you kind of look at our students and some of the needs across our community, what are you seeing as some of the mental health needs that we need to address that either we're not addressing, and I would point to you, Aaron, as well, and Val, if she's on the call, as far as things, and Jenny, you see that in the schools as well, that we need to make sure that we are there some things that we need to do a better job on or put more focus to, or where else can we be most impactful with working with our students in mental health? That can be opened up to anybody. I was just picking on Aaron there for a second because he kind of brought it up. But are there some things that you're seeing? I mean, obviously, getting kids back to school in person has had, and I see it with my own kids, is just the impact that that's had with from a positivity standpoint. but also from a perspective of, are there any thoughts that the committee has as how we can, any services that we need to be providing or doing a better job with regards to the mental health services that are already out there?
Well, one of the things that I'm not sure, I'm still trying to figure out a way to gently say, is that nobody in the district are mental health professional. Well, maybe the psychologists, but they're not, it's not the same as a clinic. Folks that need to folks that need help should get help. You know, on the one hand, there's morale, but on the other hand, there's supporting someone that actually is having a mental health crisis, or at least a chronic troubles in their lives. Yes, we want to help them. We want to be supportive. We want to be helpful. We want to give support. I'm sorry, it's past my bedtime. But there's only so much that we can do. So that is the dilemma that teachers find in the classroom, or at least me and the ones I speak to.
While our student services staff, our social workers, psychologists, and counselors are not therapists clinically, they do make up school-based mental health services. So if any teacher has a concern about what they're seeing or hearing from students in their classes, they certainly should get in contact with their building level psychologist, social worker, or counselor, and then that individual has access to some additional resources that they can hook them up with. So, and I think that's one of the challenges that our student services group is having right now, because we don't have a full day or a full access to students right now. They don't want to take students when they are there out of the time that they have for instruction to do some of the things that they would normally do. But I think if the teachers who see and work with the kids on a more regular basis see something or hear something, they certainly can get that information to one of their building level resources, and then they can work with the parents to see what the appropriate next steps would be for that individual. That's kind of how we have to operate right now, just because we have a smaller time of availability, and we don't really want to disrupt the instruction that's happening to do some of those things.
Many of the members of our committee here also are parents. Are there things you see with, in generalization, either your own children or broader community children that we need to be more mindful of? And we've certainly built things into our schedules to try to allow for teachers to have time to connect with kids more specifically. We've tried to, we're doing more. I know that there's part of each one of our levels has different activities that we're working on that truly are geared at student mental health. But are there things that you're, and I thought your distinction, Aaron, is accurate. You have the kids who are just, they're excited to be back to school. It's helped their attitude as far as being more present with their friends, back in a normal routine at school. And then there's kids who have diagnosed mental health challenges that need some additional level services. So, I mean, the question that I'm posing here, I realize is a very broad one, but it's one that I've been, as we talked to a few parents, they've asked that I bring this here to see what else we can be thinking of that from a district that we're either not doing or we need to figure out how we can help provide some of those things. And it's kind of a broad
Randy,
question.
Valerie, yeah. Can you hear me?
Yes, I can.
One of the things that I see both across the district, but also in talking to various friends, is that there's a lot of kids with undiagnosed or very mild symptoms of anxiety in which returning to school is often a big trigger. Because they've spent so much time staying safe and washing hands and wearing masks. And when it comes to things like eating in the classroom or anytime the mask has to stay off, there are some kids who are getting nervous about that. And in my experience, there's a tendency to think that anxiety looks like, I usually act it out with nail biting, where it actually can come out looking very different from that. And so I'm not sure what is being done from a student services standpoint to help kids cope with those feelings that are coming up, that quite honestly at this point are pretty natural. I'm not sure any of us don't have some level of anxiety to be around somebody else and take off the mask to take a drink or eat a snack. And so there's kind of that is one of the things that I've seen both in working with kids as well as talking to my friends about their own children returning to school.
All right, thanks, Valerie. Anybody else have anything to add to this?
I have something, just one concern that I've had as we've brought back the planning of bringing back 5 through 12 and maybe even at the elementaries is, you know, if this whole spacing requirement or recommendation goes on for a longer time, I could see that even causing maybe more anxiety in kids, and especially because not especially, but for in the health office, for instance, the health office is often used for a place for kids with mental health, particularly anxiety during the day, to kind of reset, regroup, rest, and just kind of get a quick turnaround to get back to class. And because, you know, not that we're saying kids cannot come to the health office, but we're trying to limit, you know, the possibility of exposure in the building as much as possible. You know, we're definitely discouraging it. So I just feel like the longer that all these recommendations are in place, there could be increased or different needs that the kids could have long term.
Okay. Oh, great. Thanks,
So to
Jenny,
that
for sharing
point, Randy, to that point where you're discouraging kids to go back to the health office,
Right.
is there another place where that you could designate in the building to reset?
Right.
Is that a question for me? I couldn't really hear.
Yeah, that's a real building specific question. Some buildings have more space than other buildings where that might be a possibility. I think another question becomes the supervision piece to it. For example, we wouldn't be able to divert the health office staff to another location because they have to be available to staff the health office as well as the isolation room that we have set up for kids who do have COVID-like symptoms. So it's a space and a staffing question, and I think that's very dependent upon the buildings as to what is available. I know the middle school, there might not be a lot of options at the middle school. And if you think of middle school kids, for anybody who had middle school kids, they're kind of an emotional wreck anyway, just because of what they're going through as an adolescent. Other buildings, there probably is some other spaces that we could tap into. The question then again becomes, do we have someone to staff it?
Yeah, and I think, Jenny, that's a really good question to bring up. And Jack's follow-up was, if not the health office, then where? So where could a kid reset? That's a good.
And I have addressed this already with student services staff in some of the buildings, just so we kind of had a plan going into this,
Okay.
particularly with grades 5 through 12, the schools that I am in. And so we have a temporary plan for now, and it hasn't become an issue, but if you just think of it, if it lingers, a different space may be an option that we have to look into.
And that's a good one for us to follow up on. We have a administrative meeting tomorrow morning, which I'll bring that item back to all of our staff and to see kind of what our plans are within each of the buildings. So thanks for that, Jenny. Any other pieces on mental health services? All right. I think this will be a continued topic that we'll continue to bring back here, particularly as we kind of get a better handle on some of what some of our needs are. We'll follow up with our student services and bring back, we had a report on this a meeting or two ago. We'll do that again and make sure we have some of our other student services staff here present as well. Moving on to our last question that we have for you tonight, and this is with regards to lunch. One of the pieces that we've had planning conversations on is particularly in our 7-12 model, there would be opportunity as we become, as our data shows success, as we're able to get more comfortable in our model, potential that we can expand potentially even our day. That would include serving lunch at school. Certainly is a piece that we hope to find that as a place to come back to some normalcy as far as how we kind of service kids at school. Wanting to kind of see just, right now the information that's out there and how you do lunch at school is really out of the CDC and through Wisconsin Department of Health Services have some broad recommendations around that. But certainly wanted to kind of bring that piece here, that as you're dealing more with food, which requires you to be unmasked, I mean, we've played around with the idea of how do you socially distance within a cafeteria. We've looked at tables versus having desks set out where you individually would sit at a desk as opposed to being sitting around a round table all facing each other or across a rectangular table. But we're looking for some feedback from this committee as far as we start to plan around those type of items, what type of feedback would you have that we include in our discussions and in our planning around that?
Yeah, I think, at some point you have to look at this. I think as case numbers go down, it becomes more reasonable to think that you can reduce that risk of folks being unmasked. I think then the things you want to just preserve as you think about how to set that up is distancing becomes even more important because you are removing the mask. Having people not facing each other, mouths open would be helpful. I think the thing you want to try to do is find a way to keep volumes down. I don't know. I remember when I was in high school, lunchroom was a pretty loud, noisy place. The more more noise they're making, the more they're kind of getting up there in volume, the more you're going to create droplet. Then you start having problems with your 6 feet of distancing. If you're creating a lot of droplet, you might need more. So if you're going to keep 6 feet, I think you try to keep people for the most part quiet. And then, I've heard models where you try to keep them in a classroom so that they are kind of separated. That would help you a little bit with contact tracing. If you had a positive, you wouldn't have to contact trace that entire lunchroom or people that were close. But that might not be doable. If you can't do that, I think something that keeps them separated, but maybe all facing the same direction to kind of minimize the temptation to laugh and cackle together like we would typically do might be reasonable. But those would be kind of the guiding principles, and I think you just apply that to the spaces you have and the conditions you have, and see what you can come up with. It's a little bit higher risk situation, but if numbers go down, community prevalence is lower. I don't think it's a never thing. You just have to know what you're getting yourself into when you go for that.
All right, great, thanks, Joe.
And I would agree with that. I think that you mentioned the desks versus circle tables. I think the circle tables just sort of invite people to be sitting facing each other. So I think if you have that option, being able to sort of structurally make it difficult to do the wrong thing, so to speak. I think also thinking about how you space those out, to Jeff's point, get the volume of students down as much as you can. So do you extend the amount of time that you're doing lunch if you have to do it in shared spaces where you have a very brief period of time and you have a group for 15 minutes or however long and then another one, and maybe you extend it out a little bit, just to make it more feasible. But I think it's really about the volume and the spacing, how you do that, and how you, the way we do it, and we try to minimize it as much as possible. But from the same household, you could conceivably sit at a table together, but that's kind of hard to police. And so I think one person per desk and space them out as best you can.
Okay, great. Any other feedback on the food piece?
I think in terms of students purchasing lunches, the more that you can have prepackaged and to kind of help move those kids through the line and prevent other kids from walking through the line and breathing on the food.
Okay.
I worry about the effects on the community because we've all come to rely on Topper to provide our family dinners. If we start feeding the kids, we're going to have a hard time with these family dinners.
So kind of just to summarize what I heard, social distancing being important, kind of the trying to get away from the facing each other piece, so desks may be better than tables. And then certainly if there's ways to keep things more contained within, as opposed to just having things wide open as far as the food delivery. Yeah.
I've been reading a lot about this on some other school board stuff. Some of the ideas I saw were using row tables, because you can't get rid of tables because there's usually too many kids. You don't have enough desks to drag out there just for lunch. Using row tables and everybody has to seat the same direction was one thing, but the one I thought was interesting because it's so hard to get the food to the classrooms and keep them all in all their classrooms. What they were doing was alternating days when, like a lot of them were hybrid where it was, Monday, Tuesday, or Thursday, Friday. So on Monday, one set of classrooms would go out to the lunchroom, the others would stay in their classroom and have the food delivered to their classroom, and then they would alternate the other day. So it wasn't always the same, but it got rid of what seemed to be the two biggest problems was too many kids in the lunchroom at one time, and the other problem was you couldn't get all the food to classrooms fast enough to get through lunch either. So they kind of split the difference, and that seemed to be a way to at least cut your population in half both directions.
I think the limiting factors we found is just the classroom piece becomes twofold. One is the supervision issue, and the second piece being just the travel time between where food, if it's delivered, it's one piece, but then it's, how do you logistically do that? And we've looked at we do have with the hybrid model right now, we don't have as many desks in classrooms. So desks can get pulled out of classrooms and can be distanced in the lunchroom, therefore getting away from some of the tables. So we're trying to look at all of those spaces as we get more comfortable in this model, looking at this being a potential area that we could expand in, again, as Dr. said, as some of our numbers continue to stay low and as we're able to gain some experience with the work that we're doing. But Tim, I know you're in the back of the room here. Are there you've been working on the 712 piece here. We have a meeting tomorrow on this topic. Any questions that you specifically would have as we're talking about this topic?
I don't know. Is this?
Yep, that's what.
Okay. I mean, I think, what we've heard has been very helpful in terms of the conversations we've been having. I know our initial run that John Kramer, our facilities director, has done to do an initial evaluation under one scenario, puts desks all facing in one direction in spaces we're considering. The desks would be 6 feet apart, edge to edge, so center mass for the student would be an 8-foot distance, we calculate, everybody in one direction. We've considered the classroom, our considerations about the classroom, there are a lot of recommendations, a lot of positives for it. However, sooner or later, despite the best efforts of our custodial staff, we put that much food out into the building, pest control will become an issue at some point, and we also need to provide our teachers with a break, and supervising in the classroom provides some complications that way. So that's our first cut, and I guess the other thing, and schools aren't hospitals to be sure, but if there are any protocols or lessons learned from the larger medical facilities where staff do have to take some kind of food break on the facility's premises, kind of what the procedures are for that could be shared with us in some detail, that would always be welcome.
Yeah, and we can talk to our folks and get you the materials, but it is kind of what we're talking about. If I look back at what we're doing, we minimized volume, so there's no visitors or anything like that. The physical environment is set up such that it's hard to break the rules, so chairs are removed, tables are spaced, so that even if you wanted to sit together, you can't really, because nothing's set up to do that. And then I think, the other things that you try to figure out, ours is more cafeteria style, but you try to figure out how do you prevent queuing as people are waiting for food. So you don't want, a line of people, head to head waiting to get food, so make sure you accommodate that. Self-service, probably not a great idea. You want people using tongs and serving themselves and then having that tongs be in 100 different people's hands. If you have food service workers, that's different. They can take measures that prevent that, and they can, dole things out and then hand it to people. But it's pretty similar. It's really, when you're going to take the mask off, you really rely on distancing. So then you set up your physical environment to maximize that as much as you can. Within the constraints of what you got going on, I think we completely understand that having people eat in each and every classroom creates just problems that just make it not doable. That's probably okay, but then as you look at your cafeteria spaces, doing the things that you're trying to do, desks 8 feet apart, keeping in mind how you're going to get kids in, how you're going to get kids out so that they're not, backing up, lining up, and then how you're going to do food delivery such that you don't risk the chance of cross-contamination in that process. And then I think, especially as community numbers get lower and this risk actually drops, there's probably ways to do that without taking on too significant of a risk.
Great, thank you. Great. Yeah. Any other feedback or questions around the lunch question? Dave, that comes to the end of what we've put out there.
I did find my data problem, and it's why didn't anybody see this? There are more than 6 high school students who have tested positive. Let's try 60. I forgot a 0. So it's 60 high school students tested positive for a total of students testing positive across the district of 144.
Great. Thank you, Kurt. All right.
Sorry to push the math skills.
Yeah. All right.
So are there any other comments or anything, more importantly, anything anyone thinks we haven't been looking at that we need to start to consider? Now that we have all the classes open. I'll take that as a no. Then I guess I'd be open, we have to set the next meeting.
I guess the only thing is if we want to, I know Bill wasn't able to be here tonight because he had village board. So if there was a way we could schedule it around so that he'd be able to participate. So if that would either be maybe even another night, do like a Tuesday or a Wednesday night. When the other ad hoc meeting meets that week.
They usually meet on the 3rd. Well, it's March, so there was a bunch of weird things happening in March. So they're not meeting until March 30th, but I guarantee you they'll probably have another meeting.
But we could do the first week in March if we went on that Tuesday.
That should be good. That would be the 2nd.
The 2nd of March. Would the 2nd of March work for people?
Yeah, looks like it.
Okay.
Yep.
Yep. Yeah, that way Dr. Ranum could hopefully participate with not interfering with his other meetings. Awesome.
Okay, so March 2nd at 6 p.m.?
Yep.
Well, thank you very much then. We'll be open to a motion to adjourn.
Motion to adjourn.
And a second.
Second.
Brian.
All those in favor, say aye.
Aye.
All those opposed, you can stay on Zoom as long as you like.
Great. Thank you, everybody. Appreciate your time tonight.